this anyway. Okay.
Yep.
So I'm going to share my screen. Okay, so you should be able to see my screen.
Yeah, I think so.
Oh, yep.
Yep. Okay. Now I'm going to find. Oh, there it is. Okay. Okay.
That's it. Yep.
Okay. So, so this is Alex. Okay. And Alex is about 12 or 13 years of age. So I'm just going to see who's on audio. Okay. So I'm just going to unmute a few people. Okay. So at the moment, Virginia and Jim, you're the two who are on audio.
Great.
All right. Over to you.
Okay. So this kid comes in, and how would you describe the facial profile?
That's a cant that make me impressed.
Okay. Well, what about his sagittal?
He's convex, yeah.
Yep, convex. Yeah, he looks a bit class 2 skeletal to me.
Yeah, he does. Yeah, and his mandible's a little bit to the left, is it?
Probably a little bit to the patient's right as you're looking at him. Probably a little bit to the left. Yep. Okay, but his upper midline is not too bad. But now looking at that photo, and Virginia, you sort of alluded to that. He looks like he's got a bit of a cant.
Quite a cant.
Yeah, the problem though is you're not seeing the eyes. Okay, so because we've got to block out the eyes just because of recording, etc., etc. But the problem here is that unless you see the eyes, I mean, he might have already had his head tilted as well. So when you assess the cant of the occlusal plane, you really want a half-open photo, but with seeing the eyes and making sure the eyes are parallel to the floor. Okay, because he could have his whole head tilted, and if you look at his eyebrows, just for argument's sake, if you just look at his eyebrows, he probably has got his head tilted a little bit down to the right. His right eyebrow looks a little bit lower than his left eyebrow or here. So I wouldn't use that photo as a really good guide to his cant, unfortunately. Okay, so so his upper lip looks pretty good. Okay, he's got, how would you describe his Ceph? Because remember, the Ceph needs to confirm the original, your clinical findings.
Deep eye.
Yep.
He's almost class 1 skeletal, isn't he?
He's not too bad.
Yeah.
He's not too bad. Yeah. So ask yourself, if he looks class 2 from a facial point of view, but his Ceph looks class 1, what could be the issues?
Some of it's soft tissue contour and things, but also posture, if he's actually...
Exactly. I mean, we don't, the problem is you've got a radiographer taking the X-ray normally, okay? So you don't know whether he's been postured forwards or not, but because you've got to look at the amount of overjet here compared to the amount of overjet in his clinical photos, which I'm going to show you in the next slide. But it could just be just a deficiency in the hard tissue of the chin. To me, he looks a lot more retrognathic in the photograph than he does in the lateral Ceph.
Yeah.
And in the Cephs, a lot of the time they get the kids to tip their heads up rather than adjust the machine.
That's exactly right. So if you look at A point and then B point, he probably is still a big class 2. If you're looking at the actual true B point, which is here, and A point, which is here, he probably does have a bit of a class 2 skeletal situation. Now, I apologise for the next slide because it probably tells you everything anyway. Okay, so here we are. We're a class 1 molar and bucket, a really nice class 1 on the right hand side. A really nice class 1 occlusion on the right hand side, and on the left hand side, I'll move that out of the way. On the left-hand side, he is a full class 2.
Yeah.
Okay, so he's a full class 2 on the left-hand side, and he's a full class 2 canine on the left-hand side. Now, I'm not going to... But we already assessed that his upper midline was correct to his facial midline.
Hmm.
You know, when we looked at him from this photograph, so his upper midline is pretty well on. Okay, so here we are. So full class 2. So what are our options here? You can see what I've probably done, but okay. But what would be, if that was your patient, what would be the options for this particular patient?
You'd want to replace the 4 that was lost. Oh, no. Oh, no, sorry.
Well, I'm going to tell you now. We extracted the upper left 4, okay, to correct the unilateral class 2 relationship. But there are some real issues with doing this. So, what are the issues?
What are you talking about?
Look, getting the space closed, how much are you going to have to open his bite and intrude the lower incisors? Because it doesn't got that much space relative to it.
Yeah, what else though? What's the main issue with doing this approach that I've decided upon to look at to get the
midline's going to move, and your bite might deepen a bit more.
Yeah, well, the bite might deepen a bit more, okay, but I'm going to resolve that with some mechanics, okay, because I know that anyway. But
and if he does actually have a cant to that side, that's also...
He probably does have a cant to that side. So tell me, if that's the case, the midline's going to move off, and that's a real issue for you. What are your other options then?
You'd have to extract the other 4.
Okay. And what are you going to accomplish by extracting the other 4?
Hold the midline there.
Now, if I extract the other 4, right? I don't want the. Okay, I want to maintain that canine, correct?
Create a class 3 canine.
Yeah. So if I took out the upper right 4, all I'm going to do is move. I would have to have then a totally minimal anchorage approach and move the upper right molar all the way forwards.
Yeah.
Which makes no sense whatsoever.
No.
Because how could you achieve a total minimum anchorage case?
You'd have to have little implants in there.
Yeah, micro implants and all this other stuff as well. Okay. So what other options do you have?
You could have left it there and accepted the overjet if that wasn't a problem to the patient.
Okay, absolutely. So you do like a bit of a Smilefast approach, but let's say you're looking at getting a perfect occlusion. You could have suggested maybe an asymmetrical mandibular advancement, because that look where your lower midline is.
Yeah. Is he still growing?
He would be growing a little bit. Yeah, he's 14. So you could have done it with a Herbst appliance or any functional appliance but you're advancing the mandible a little bit more to the right hand side,
which would also possibly have helped to distalize that molar a bit.
A little bit, yep.
Earlier on, would a functional appliance have been helpful if it was?
Probably. If you really want to maintain the midline, yeah.
Is that asymmetry on the lower midline, is it actually partially functional? Is he sort of swinging his jaw to the left to compensate for his bite?
I reckon 90% there will be some functional shift. The problem is where. Yeah, to pick it up clinically is just about impossible. And so what you end up doing is you end up coordinating the arches, and at that point you're basically hoping that you've got rid of that functional shift by coordinating the arches. Because usually the functional shift is related to some lack of arch coordination. So yeah, more than likely it's probably a functional shift Yeah, where he's hitting that canine and then sliding his jaw forwards. But it's so difficult to tell in a lot of cases. But I agree with you. I think there's definitely a functional shift. So what other possible option, and I actually told you this in one of these other courses, okay? You may have forgot this, okay? But Vince Kokich, have you heard of Vince Kokich?
No.
Vince Kokich, when we get to the interdisciplinary stuff, we're going to talk a lot about Vince Kokich. Vince died about 3 years ago now. He would have been one of the greatest orthodontists the world's ever seen, okay? And one of the greatest thinkers in orthodontics, okay? And Vince and Bjorn Zachrisson were sort of the two leaders in adult orthodontic treatment. So Vince used to work a lot with Frank Spears, the prosthodontist. So Vince and Frank Spears and a guy called David Matthews used to run an interdisciplinary study club. And myself and Andrew Dillon and Peter Allen, we went over there and visited them. And it was the most amazing 3 days we ever had in my life. It taught me more in 3 days than I think I learned in 5 years. So, and Vince would say to you, if you've got a unilateral class 2, like you have here, and the lower midline is off, because what I'm going to be doing is taking out that upper left 4 and moving everything around and coordinating the midlines, but not really looking at the upper midline, okay? So I know the ideal choice is to actually open up a space for an extra premolar on that lower left-hand side. So you're actually pushing that lower left-hand side forwards, and you're going to open up one further premolar tooth. So you're actually going to move this anterior segment forwards to get a class 1 canine relationship.
How's on that lateral ceph? What does how are the incisors sitting? The lower incisors in the bone.
Good question. They're probably already a bit proclined. So you're probably going to procline them further. You would have to add a lot of root torque, a lot of labial root torque to stop the further proclination of those lower anteriors. If you were doing that, that would be the textbook academic ideal treatment of choice, which is very, very, very rarely ever suggested, very, very, very rarely ever performed. Can you imagine telling a patient you're going to now end up with an implant and an extra tooth? Very hard concept to try and sell. But technically speaking, it would be the treatment of choice.
Why did he lose the upper 4, the left 4?
Jeff said so.
Because I'm taking it out.
Oh, okay.
Because my treatment plan is to take out the upper left 4 and move everything around and get a class 1 canine relationship bilaterally.
But rather than increase the space, you've actually reduced the space to compensate in reverse.
Yep. So that's what my treatment is. Now, you'll see some issues that have developed, and I'm going to show you how did we fix it. Okay, but the critical path to success here is getting a class 1 canine relationship. And our critical path to success on the right side is not losing the class 1 canine relationship. So Philip said, if we were to open that space if we were to open the space in quadrant 3, would that not disturb the class 1 on the right hand side? No, because we're going to leave everything the same way, and we're basically going to push the lower anterior teeth forwards and around. So our whole idea is to maintain this existing buccal occlusion. Okay. So now I want you to look at this existing buccal occlusion. What do you think? Do you think it's good or bad?
Good.
I think it's great. Okay. So one of the things that when we bracket those teeth, right? You want to be able, when we bracket the teeth, we want to see the brackets on so the wire's actually perfectly straight. So this is your guide. You're looking at that buccal occlusion when you're putting your brackets on and saying, what do I need to change in that buccal occlusion? Absolutely nothing. So you put your brackets on so they're absolutely perfectly straight. Okay? That's a really good guide, because what we normally do is we put every bracket on and we look at it as an individual tooth, don't we? So when you bracket, you just look at that one tooth, don't you? And then you look at this other tooth. But what you need to do is you need to look at the teeth in relationship to each other, because that's what you want to maintain, this good buccal occlusion. Does that make sense?
Yep.
Okay. So when you start putting brackets on, look at the existing occlusion, and then so you can see what you actually need to change in this occlusion, or what don't you want to change. If you don't want to change something, then make sure your brackets are on perfectly straight. But what we tend to do is we just put the brackets on, and we're looking at we're looking at the tooth by itself, okay? And we're looking at the height by itself. You've got to look at everything in relationship to the other teeth. So I'm just going to...
Have you got a photograph of him half open so we can see what the lower incisors look like?
Unfortunately, back then, I don't think I've got a picture for you at this half open. I've got a picture later on half open, but not at this stage. Sorry.
That's okay.
And you're totally right. That's what we should have. So we went ahead and we put the brackets on, and notice how I put the brackets on that right side. That wire is basically straight. Okay. The lower arch, it should have been straighter. Those brackets should have been much straighter on the lower arch. They were well positioned on the upper arch. But what am I going to do here on that lower right-hand side? I'm going to extrude. Yeah, I'm going to extrude those teeth. But I suppose in one way I probably wanted to, because I wanted to open up the bite a little bit. Okay. So here we are, brackets on the upper arch, brackets on the lower arch. Okay. And today I would have put, the 0014 night eyes in. These are the Ormco Damon self-ligation brackets that, and they're fine, but but I don't believe they're as good as what I call the active self-ligation brackets as in the finishing stages of treatment. Okay, because these brackets are passive self-ligation, so the wires will just be a bit floppy in the slot, which is all fine in the early stages of treatment, but when you get to later stages where you want full engagement and torque control, you're better off with a more active self-ligation bracket system. That's just my belief. But people get great results with this type of bracket system as well. Okay? You probably have to do a bit more wire bending at the end. So here we are. So this is basically in May 2010. This is March 2011. So that we've leveled and aligned, okay? But we're seeing a bit of a cant occurring on that top left-hand side now. Okay, so we're seeing a bit of...
Put that crimp stop behind the 1-3 to stop the wire travelling around while you're trying to close the space?
Yep. So to be honest, I shouldn't have had that crimpable stop so close to that upper left 3 because there's still a little bit of crowding here. So it would have been nice to allow just to have a little bit of space distal to that crimple, a little bit of space distal to that bracket before the crimpable stop, maybe a millimetre.
Should you have put the crimpable stop back by the width of the crimpable stop?
Oh, I think 1 to 2 millimetres, yeah, which will probably be about the width of the crimpable stop. But there's no actual science to that.
They look nice.
Well, they're straightening up, okay, and they're straightening up. But I have got this. I'm losing that nice buccal occlusion on that left-hand side. Why? Because my wires weren't all perfectly straight. I should have had that wire really straight at that particular point. Okay. I've now got some intrusion. I've got some extrusion of this tooth, but I've got some intrusion of that canine.
Didn't you want a bit of extrusion of that 5?
Yeah, probably. Yeah. It's probably a bit of an academic moot point, but. The only point I'm trying to get at is here we are now with this cant occurring. And we need to be mindful of it. So what would you do if you saw this at this particular point? Okay? Because we're all talking, we keep talking about risk analysis and things getting out of control. Okay.
Well, the lowers are fairly level, so you could just shift the bracket up the canine and it would extrude it, relatively speaking. You'd have to go back into a smaller wire.
Yep.
You
Now,
could
what's
bring
going to happen? That's good, Virginia. What's going to happen? I'm going to put the bracket more gingival on that canine to extrude it. Okay, because I think it needs to be extruded just a fraction. What are the reciprocal side effects of all that?
may tip the canine in a little.
Yeah, may do. What else?
You could end up, because the canine's a heavier tooth than the lateral, you could end up the lateral up, like intruding the lateral first.
Yep. And what else are you going to intrude?
5.
The 5.
The 5, and you've already got a bit of an open bite here.
Mm.
So
Do
what?
as well?
Sorry.
Do you use some vertical elastics?
Yeah. Yep. So at the same time you would put some posterior box elastics on.
That'll help close the space as well if you took the crimp stop off.
Yeah. So here we are. So rather than having all these problems occurring and then spending another few more months fixing them, you want to start to think about what's going to happen as a reciprocal effect of what I do.
How do you put elastics on with that type of bracket? Do you have to put a Kobayashi tie or something on?
Sorry, which one?
Well, like, there's no little elastic duvers on the canines of those. Do you have to have Kobayashi ties, or is there some other way of doing it with these?
With the Damon bracket, they have there's a little hole in the Damon bracket, so they're what we call drop-in hooks. So you put a drop-in hook here, but with all the other brackets that you're going to be using, they've already got the hooks in place.
It sounds like it's called a drop-in hook because it'd be easy to drop it down the back of someone's throat, actually.
Yes. Yep. So,
I'll just ask a simple question. Why have you got those crimp things, but on both 3s?
Because I just don't want this. Because when you deal with self-ligation brackets, because there's not much friction in the bracket system. You know, when you tie in with elastics, there's a lot of, and I'm going to go through this with you in the next module about friction. Okay, and when you use self-ligation brackets, there's not much friction, so the wire can actually slide around.
Oh, okay.
So is that also why sometimes people put coloured elastics over self-ligation brackets, just to jolly along the kids, or is it actually useful for? No,
it's not useful at all. It's purely to jolly along the kids. Okay. In fact, the real proponents of self-ligation, when they first came out with Damon, the whole idea was why teeth they claim move faster was because of the lack of friction. So they wouldn't put self-ligation brackets. They wouldn't put coloured elastics on at all.
Put them on just to save the waste of time.
Well, it is a waste of time, because not only do you have to put them on, but then when they come back a month later, before you can open the clip, you've got to take them off again.
Mm.
Yeah, so a lot of people don't like using colours with the self-ligation brackets, but but that's what the kids want, and we're going to make them happy. Yeah, so now Phillips asked the question: would you make the gingival recession worse on the 2-3 if you intruded it? Well, I'm going to say yes and no. I don't think you will, because whenever you extrude a tooth, you bring down the gingival margin with it. Whenever you intrude a tooth, the gingival margin goes with the tooth. The only argument, theoretically, if you intrude that tooth, theoretically, what will also happen is you'll get some flaring of that tooth, but you'll get the root going further palatally. If the buccal starts to flare lately, the root may go more palatally. So I really don't think the gingival recession is going to be a big issue, because one sort of balances out the other. So I don't think that's going to be a big issue. So here we are. So we're now into into 2020 night eyes, which is what I call intermediary alignment wire. So here we are. So from these 2020 wires, I would have gone into a 1925 night eye, and I would have then gone into a 21 by 25. After I've levelled with the 21 by 25, and this is the key, I believe, whenever you do extraction mechanics, which nobody else teaches you. They all teach you go into 1925, like Jimmy, with your POS. What do? You go into 1825 night eye,
Yeah, the heat activated one, and then the 1925 stainless steel.
Yeah, well, the whole idea of sliding mechanics is, which is what you see here. See how we've got these posted hooks and we've got these power chains?
Mm-hmm.
Okay. So what we want now, what we're going to try to do is slide all these teeth back on the wire. Okay. But in order to do that, you need that wire to be perfectly straight.
Mm-hmm.
Okay. Now, you need that wire to be perfectly level. So when you go from 1825 nitide to a 1925 stainless steel, okay, the wire is not fully flat at that particular point. The best thing you can do is go to a 21 by 25 nitide and then drop back to a 1925 stainless steel. Now, do you ever have problems, Jim, in putting your 1925 stainless steel in?
Yeah, I have had. Yeah.
Yeah. When you do it this way, Jim, if you do your 21 by 25 and then you put your 19 by 25 stainless steel in, probably about 10 weeks later, okay, you will see that 1925 stainless steel slide in like butter. It will, and that's when you know you're going to get a lot of sliding mechanics. If you have to really force that 1925 stainless steel in, there's binding, there's friction. Those spaces will not close up. That is the biggest problem why spaces don't close, is that friction and binding. So we've put in a 1925 stainless steel. We've put our power chain on. You can use closed coil springs. You can use whatever you like, but it's just a force to close up the spaces. That's all it is.
So you go, what, 20 by 20 nitide, 19 by 25 nitide, 21 by 25 stainless steel, 19 by 25 stainless steel.
Sorry, say that again. 20 nitide.
Yeah, 1925 nitide.
Or sometimes I'll use a 1925 TMA. For example, if I want to put some reverse curve of speed in there. So if I want to level the wire, and I will show you how to put reverse curve of speed in wires, okay? But usually it's a 1925 nitide, correct? Then I go to a 21 by 25 nitide.
Oh, nitide, not stainless.
Yeah, 21 by 25 nitide. I leave it in for at least 8 weeks, preferably 12 weeks. Yeah, somewhere between 10 to 12 weeks. And then I will take that out and I'll put in a 1925 stainless steel. And I use these posted wires, but you could just, you'll see in a slide later, we put those crimpable hooks on. So yes. you don't have to buy wires with these hooks, okay? I just do because I just do a lot of cases. But you just have 1925 stainless steel wire and you put a crimp a hook on. But now you've got to make sure that hook is really, really solid, okay? So it doesn't slide. And make sure, let's say you've got anterior spacing here. Let's say you had some spaces anteriorly, then you've got to make sure you've got enough space distal to your hook so it will slide. Because if you put your hook right up against the canine, then you won't close any of that anterior spacing.
Jeff, why, if you were fairly happy with the right side, do you have the elastic chain on that side as well?
Because if you don't, what's going to happen? The whole wire is going to if I just put power chain from the upper left 6 to the hook without holding this side, what's going to happen? The wire is just going to slide around.
Yeah, I understand that, but could you put a crimp stop on instead?
No. Well,
no.
So let's say you put a crimp stop on, for argument's sake, where would you put the crimp stop on?
Just distal to the canine.
Okay. So then, if I'm doing that, what would happen is the crimp stop, the wire would slide around, and I would have pressure distal to the canine, and I would get a space opening between the canine and premolar.
Yeah.
Does that make sense?
Yeah.
Even if you don't need to retract, you should keep equal force on both sides.
Yeah.
That's an important point.
Absolutely. Now, the problem here was your anchorage that we're going to talk about, because I started closing up these spaces. What happened? I've now got a little bit of a class 3.
Class 3.
Okay. Don't ask me why that's happened, because you would have expected it to be the other way. Okay. And
Case that's doing that at the moment.
sorry.
I saw a kid yesterday who has developed a slight class 3 bite when she was class 2
Yep.
from class 2 elastics. She's actually my general patient and she's seeing an orthodontist. And the parents are a bit unhappy.
I'm a bit worried. Yeah, now, in all honesty, that's probably not bad, Virginia.
No, I actually said it would work out because it was better to go too far and be able to bring them back. But
Absolutely.
trying to support my orthodontist colleague too.
Yeah. So at this particular point, before you have a cardiac arrest, because I've still got space. I've still got space distal to that upper left canine that I'm going to close up. So what am I going to do now? Because this comes back to always, what's our critical path to success?
The class 1 canines.
Exactly. So that's what I'm looking at. How do I get that now? What are the things that I'm going to need to do?
Is much of that
Class 3 elastic.
Yeah. What else?
is much of the bite postural?
Oh, I don't think so. It could be a little bit, but
Yeah, I agree with Jim. Class 3 elastics.
and what else?
Prayer.
Sorry.
Prayer.
It depends on how religious you are. I just pray to myself. I find that works a lot better. Do you remember in module 1, okay, you induce a Bolton discrepancy because of the flaring of the lower anterior teeth.
So a bit of IPR in the lowers might help then.
Exactly. So I'd be doing IPR in the lowers, and you can see I've got power chain on the lower arch.
Yep.
So I've actually IPR'd the lowers, power chained the lower arch, and I'm going to wear class 3 elastics. Okay.
So how did that class 3 develop? Because
Well, the class 3 on the left side is understandable because I'm moving teeth back. The class 3 on the right side, I'll be honest, I've got no idea. No idea. There's no logical reason for it. Because if anything,
horizontal growth.
yeah, well, I reckon they have had some growth. Because if anything, as I close this upper space on the left, I'm going to move everything around. I should have made that class 1 on the right a bit more class 2.
What was his profile like at this stage?
Honestly, I can't remember, and I didn't take a profile picture, but I would imagine he would be looking a little bit bimax protrusive because of the lower incisors being forward, and he would, his lips would be pretty full.
Yeah.
So here we are with the class 3 elastics as discussed, okay? And I've just done class 3 elastics only on the right-hand side.
Jeff, when you do that sort of thing, sometimes with patients where I've needed a unilateral elastic, I've been getting them to wear them bilaterally to bed at night because I figured that their muscles being passive, it could end up swinging things around. Is that really stupid?
I'm not going to say it's stupid, but if you really only want correction on one side, I don't see the point.
Yeah, I was thinking of trying to compensate for the fact that their muscles are fairly relaxed at night and their jaw may end up swinging to the side that you're trying to get the correction on and losing the stretch.
Yeah, look, I honestly, I can't answer that question. Yeah, because I do elastics at night on one side, but that's more if I just want to maintain that side.
Yeah, that's what I'm asking. What I do is I get them to say where, like on the side I'm trying to keep things stable, I only get them to wear the elastic at night, and then I get them to wear the single elastic during the day when their muscles are awake and not flirby.
Yeah, but that's if you want. Yeah, that's if you want to maintain it. Here, I don't. Here, I really just want to correct this class 3 on the right side, and move that lower midline around.
Yep. So you'd be happy to just accept the fact that his jaw may swing to the right during the night?
Yeah. Well, look, this is one of the reasons why you need to see these patients every 6 weeks.
Yeah.
Because you have that. These are the decisions that you need to make every 6 weeks. Even with the best plan in place, there are some things that happen that you just can't predict.
Mm.
But the more you can predict, the better your treatment results going to be, obviously.
Yep.
On that left side where you're closing that space, you're gonna have on one side you're fixing that class 3, but the other side you're sort of making it class 3 still.
Well, I've got a class 1. Yeah, well that's right. So I may have to run some class 3 elastics on that left-hand side later on.
Oh,
okay. And these are the things that I need to figure out.
But if you started doing the, oh no, sorry, no. I was just thinking you don't want to do class 2 then, no.
No, I definitely don't want to do class 2s at this stage. Okay. So I've had 2 really good questions. One by Philip, which says, what are the unwanted side effects for doing unilateral class 3 elastics, and how do you counter it? Well, that's a good question, because you're going to get some extrusion of the upper right hand side, okay. And remember, they already had a bit of a cant to that occlusal plane. So, okay, and you're going to get some extrusion of the lower anterior segment. Okay, minimal, but you will get some. Now, having said that, Philip, you're on a 1925 stainless steel, so you're probably going to get minimal side effects here. But if you were concerned by it, you might put a little bit of a bite turbo on that 6 to stop that 6 from extruding it at all, because you don't have much overbite here, so you don't really want much extrusion. You don't want any extrusion of that molar, or else you're going to open the bite further. And then the other comment that we just got was from Keith, which was really interesting, was the right-hand side class 3 possibly due to an occlusal interference as the teeth move forwards. Okay, so and that may well be correct. This may all be related that there's an occlusal interference somewhere, and the jaw's sliding off. So yeah, that probably is the most logical explanation of why we developed a class 3 on that right-hand side, which I wouldn't have thought, to be honest, until you said that. So let's keep going. So here we are. Where are we? We're there. Okay, so they're the class 3 elastics. And so I played around with class 3 elastics on that right-hand side, and I would have ended up with some class 3 elastics on the left-hand side. And this was all done on the 1925 wire. And these are the surgical hooks that we're talking about. Okay? That you just crimp on the wire. And then what I would have done, and after I finished all that, how would I have finished this case? Because this is what we achieved. So even though it looked pretty bad at one stage, just by monitoring the class 3 elastics, and let's have a look at his facial profile.
That's good.
It doesn't look too bad.
And
his midline is not that far off. I don't think his midline has got that much worse. He's still probably got the cant to the occlusal plane. So it's not bad. I think anybody would be pretty happy with that final result. So how did I finish him off? What do you think I would have done for the finishing stages, as I taught you in Module 4? So Jim, we've gone through that wire sequence of 20 squared, 1925 night eye, or 1925 TMA, but probably 8 times out of 10 will be a 1925 night eye, then to a 2125 night eye, and then to what I call the working wire, which is my 1925 stainless steel. Okay, sliding mechanics. If you want to use the closing loop arch wire, all the same type of thing. Okay. Then once I've closed the spaces, I would have taken an OPG and lateral ceph, and today I'd be taking a cone beam, and I would do some rebonds if I had to, and then at the very end of all that, I would finish off with a braided wire, a 1925 braided wire, running some posterior box elastics. And that's how I would sock that occlusion in. So the braided wire is a very soft wire that will just maintain your alignment, maintain your torque, and then with the rubber bands can overpower, in the posterior segment, posterior box elastics, can overpower that wire to help sock in the occlusion.
But you've corrected that class 3 just with the elastics, did
Just
you?
with the elastics.
That's a huge change.
It was unbelievable. But it was monitoring that, it was monitoring in the canine relationship all the time.
Do you ever use those zigzag elastics to sock things in?
Yeah, I very rarely do, but I very rarely do. I just find it difficult for the patients to do it, and you really need them hooks on every tooth, and normally hooks on the 3s and the 4s. Okay, there are some people who take out the wires, and they use the zigzag elastic, so they'll only have the wires so distal to your canines.
Aren't they the people you said were a bit brave?
Yeah, and I was going to say that again. I find that very brave because things can get out of control. But the people who swear by it, you get beautiful socked-in occlusions by doing so, because it's a little bit like the free class 2 elastics. There's no resistance. The teeth are going to move so quickly.
Do you have to use a braided wire, Jeff, or could you go back to, say, an 014 night high to finish that off?
Well, the problem with the 014 night high is it's always going, well, the 014 night high, it's going back, it's always got the force to try and go back to its original position, but you're right, there's a lot of slack in that wire, so theoretically you could. The problem though is, why I like the braided wire, is when you're using these vertical elastics, Virginia, what else is going to happen to those teeth?
Well, start to tip lingually a little bit.
Yeah, exactly. So the braided wire, which is a 1925 braided, has some torque control.
Ah, right, yep.
Okay, whereas if you did it, now there are people who they wouldn't tend to recommend an 014 night. I've actually never heard that, in all honesty, from the orthodontist, but they do recommend like an 016 or 018 round stainless steel wire.
Mm-hmm.
Yeah, which is
that doesn't hold the torque though, does it?
Precisely. That's why I don't like it. Now, on the other hand, if these teeth were flared out, if they were flared buccally a little bit, then that would be a really good choice, because yeah, or that concept that you just talked about of the laced elastics without a wire, because you don't mind.
Mm.
But the other problem I have with having no wire in there especially in extraction cases, because if you've got no wire in there, there's the tendency for the space to maybe open up again.
Yeah.
And that's why I like the wire, and I cinch back that wire. So that 1925 braided, I will bend that wire back right up against the 6 or the 7, the distal, so it maintains and holds that exact arch length, so spaces can't open up. And that's the other problem that you've got if you were using an 014 night eye, much harder to get a really, really good cinch back on that wire.
Yeah.
Does that sort of make sense?
Absolutely.
So I thought this was a good case, and so let's have a look at. So this is the OPG, which is pretty good. But if you have a look here, right, we took out the 4. The root could be moved a lot more easily according to this OPG, right? But when you look, when I look at it, it looks pretty good to me.
Upright, yeah.
It looks pretty good. I mean, it could probably be, I could have rebonded a little bit better, but it's not a big deal. But the purists would once again say that. But when you look at the Ceph, the lower and sides are a little bit proclined, but he's got a pretty good facial profile. He does not look Bimax at all there.
No.
In fact, quite the opposite, I think. And that's why I keep saying to you guys,
you would have made him really flat.
Oh, yeah, absolutely. And so that's the other thing, people. There are a lot of orthodontists who got taught back then, if I take out one premolar, I've got to take out 3 others. Okay? And you don't have to. And that's why you got to, like you said, Jim, at the beginning, well, I would take out the upper right foot. Well, you get nothing out of that.
I was just worried his whole midline had moved, though.
Yeah. Oh, and to be honest, so would I. So would I.
But how come it hasn't?
I have no idea. Honestly, I have no idea. I think what happened was the only thing I can think of here is because we would have run some class 3 elastics on that left hand side as well, which would have kept that upper midline a little bit, kept moving that upper midline around to the right. Yeah, it's one of these cases where you present it and go, I'm still trying to figure out exactly what happened here. And I think Keith's explanation of there's probably all these functional shifts that were going on. It's an interesting case, and I did actually present this to Mum about opening up the space for the premolar, and I've done that I think twice in my life. I've probably presented it, I reckon, 30 times, and I've had 2 people out of 30 accept it. And I've got to say, what Vince Kokich says, it's bloody difficult, because when I put a coil spring in between these premolars, what happens? The crowns tip and the roots tip into the extraction, into this space. Yeah. So it's really hard to open up space for a whole tooth and maintain the roots in the right position. It's a lot of work.
I've got to leave the meeting, mate. Sorry.
Yeah, not a problem at all. Hope you enjoyed it and got something out of it.
Yep. Thanks, mate. I'll see you next week.
Oh, yeah. Is it next week? Or the 21st?
No, the next meeting, one of these. We got a conference.
Oh, yes, we got another one next week. Sorry, I'm thinking we got the course.
I'll see you next week. I'll see you.
No, that's a month away.
That's a month away. Okay. Hey, Dave, you should have all your pre-course reading material now.
Got it all. Yep.
Perfect. Okay. Fantastic. And Virginia, you like the new format of the communication?
Absolutely. Yeah, it was really good. Yeah, everything all in one place is really helpful.
Yeah, you're going to get more. This is going to be routine, and you're going to get more communication in about another 3 weeks, then another 2 weeks. So you get about 4 communications where we're going to give you some different things, with the whole schedule of the meeting, et cetera, et cetera.
Thanks. All right, mate. Bye.
Okay, perfect. If you've got any suggestions for anything, please let us know. Keith, I'm sorry that we didn't get onto your case, but we'll definitely do that next week. Or if you want, Keith, we can do a one-on-one if you're there.
Jeff, I may need to organise a one-on-one with you about that case that we've been discussing earlier.
Oh, yeah. Which one's that one?
The girl that had lost her lower sixes.
Yes.
Ken's case from a while ago, and she's having upper 4s out, and they've decided to go ahead.
Okay, fine. Okay. Oh, that's the one that you're going to do the full on treatment planning process.
That's right.
Okay, you do that, because I think you get a lot more out of it when you go through that thought process.
Yeah, I have to do that today because she got me to take the impressions yesterday.
Okay. I'm away for a couple of days. I'm going to go up to Sydney tomorrow, but I'll be around next week.
That's great. I'll get it done between now and then.
Okay. In fact, I'll be around on the long weekend if you got some time and you want to do it. Yeah,
I will be. So I'll ping you a message, and if you're available, ping me back, and we'll work it out from there.
Perfect. Fantastic. You have a great weekend. Have a great long weekend, everybody, and thanks very much for your time. And Keith, let me know if you want to do a one-on-one with your... Okay. Keith, you there?
Yeah. Can you hear me?
Yep. If you want to organise a time, maybe even on the weekend as well, and I can do a one-on-one with you if you want.
I'd like that. That'd be good.
Okay. Why don't you send me an email? I'm around Saturday morning, and I'll probably be around Sunday morning at work.
Okay, that sounds great. I'll send you an email. Thank you very much.
Send me an email. Happy to do it. You're an hour behind still, aren't you?
Yes, I am. Yeah.
Okay, so we'll just have to factor that in as well. But I'm normally at work about probably. I've got a conference call at about 8:30, so about 10 o'clock Melbourne time till about 1 o'clock. I'm free on Saturday, and I'm probably going to be free, say, from 9 o'clock till 12 o'clock on Sunday.
Okay, that one of those days would be great. I'll send you an email.
Perfect.
Can I ask a very quick question?
Absolutely.
When you open that space up in the lower, did you
Yeah.
say you were going to put an implant in there or restore it?
We put an implant in there, yeah.
Yeah, cool. Okay, and that was because, is there a Bolton discrepancy in this case?
Well, there must be a Bolton discrepancy based on the lower 6 to 6 measurement, because
Yeah.
Bolton did it. We all look at lower 3 to 3. That's
Yeah.
okay. But there must be a Bolton discrepancy when you do the lower 6 to 6, because Bolton also did a lower 6 to 6 measurement, but nobody ever uses it.
Yes, because I thought if you had just ignored the midline and made the molars on the left-hand side class 1, that extraction space would get even bigger, wouldn't it?
Oh yeah, I wouldn't have. If I was going to make the molars class 1, I wouldn't have extracted.
Yeah. Oh, you extracted, did you?
Yeah, I extracted upper left 4.
Okay. Was there anything wrong with it?
No, nothing.
Okay.
It was just because we had a full class 2 on that left side.
Yeah. Okay.
But the ideal treatment, see where your lower midline is?
Yeah.
Okay. So the ideal treatment, according to Vince Kokich, would be in a class 2 patient where the lower midline is off, because what I've done theoretically is move the upper midline around. That would be what you would think.
Yes.
So if the lower midline is off, the ideal treatment plan for a class 2 patient when the lower midline is at fault is to open up the space in the lower premolar area for an extra premolar tooth.
Yeah, no, that makes sense now. I was a bit late. Sorry about that.
Yeah, I know. That's why I thought I'd just refresh that with you. Hey, how are you going with your other consult with the other person that's helping you?
Oh no, I've kind of cut that out now. I haven't asked him for advice for a while. I'm just kind of using what you're telling me.
Yep. Yeah.
So you're much better, Jeff.
Keith, I love it when you say that. I don't believe you, but I love it when you say that.
No, I know. It's true. I'm not just saying that.
Oh, okay, well that's very nice. Thank you for that.
Yeah.
I try to give. I don't like giving, as you can see, cookbook stuff.
No.
Yeah.
Thinking about it.
Yeah, I mean it's no different to you in pros. And actually, speaking of which, I want to talk to you about maybe. Do you know Andrew Dillon?
I do know. Yeah, he's a nice Melbourne prosthodontist.
Yeah. Andrew's a very, very close friend of mine. Andrew's going to give the lecture a day on interdisciplinary stuff at the end of the year. But what I'm hoping, because you're going to be one of our graduates maybe the year after, that you could take on that role as well.
Oh, I'd love to, Jeff. That'd be great.
Yeah, because I've noticed you're doing quite a bit of lecturing for New South Wales.
I am. I'm doing. Yeah, I am.
Yeah, but there is one key to when you lecture. You can't say that it'll be the next module like I do.
No, that's right. No, I'll just say Jeff will answer that.
Yeah, I loved it when they said you're entertaining.
Yeah. Well, you have to try. You are, otherwise people fall asleep.
Well, it's not. I don't care about the people falling asleep. I care about me falling asleep and getting bored.
That's true as well.
You have a great day, Keith, and we'll see you next Wednesday.
Yes, I'll send you an email. Thank you very much.
That'll be great. Speak to you later. See you.
Bye.
Bye.